We will now begin the seminar session. I now kindly request our chief guest, Dr. Nagaraj, Chief Radiation Oncologist, to give briefing about hyperthermia remission 1 degree.
Good evening. Thank you so much for a wonderful introduction. Thank you, Mr. Jinnah, for calling me here, inviting me here. As he said, we have met before, we have traveled before. And that one journey, or one which is common to both of us, is to make hypothermia not only a very popular and a reliable modality of treatment in India. It's very ironical that India, historically started harnessing heat for the treatment thousands of years ago. I'm sure, especially most of the people who look back would realize, truly can be very proud of some of these innovations right at the beginning of pinnacle of Indian medicine. When we try to think of hyperthermia or making it very popular, it's reclaiming our own past glory, right? Having said that, what I wish to talk about today, harnessing heat essentially for cancer. And in the whole process, I will also give some introduction, or I'll talk about biological basis, technologies, and our own data. And, and since, of course, many of you would be skeptics, some other data as well. As I go along, if you have questions, please, you're more than welcome to ask me at that particular time, or you make a note, and we can discuss at the end of it, or even after, okay? Next, yeah. Historically, we talk of Bush and Cooley. As I told you in the morning, that it is an act of serendipity, and they saw sarcoma responding very well in those people, or those patients who develop fever. Cooley is the one who tried to, create artificial fever, not by creating, much like the whole body hypothermia that we try to do now, by injecting certain bacteria, infective bacteria, staphylococcus, and I think patients died because of infection, because there was no adequate antibiotics. But then, what is very important is in the 70s and the 80s, when I was doing, in the 80s especially, when I was doing my MD, hyperthermia was a very hot subject. If you look at the publications, they're huge. And almost everybody was very, very, very optimistic and gung-ho about that. Suddenly, maybe the technology did not match, or a couple of randomized trials which were not properly designed did not show positive evidence, and then suddenly there was a decline in the interest. And this particular paper by my friend Wanda Z. Kobe, she's from in the Netherlands, again revived, especially in Europe, the entire interest in hypothermia. People might wonder why it never happened in the US, and there's a reason for that. America is driven by money, okay? And it took a very long time for hypothermia to be recognized by the insurance. And I also think that most radiation oncologists are generally very lazy, because they write prescription and they expect the technicians to just push some buttons and so on and so forth. Hypothermia is a labor-intensive treatment. A doctor has to spend a little more time than perhaps what he would in radiotherapy, because sometimes, especially if in a very complicated machine, you may have to adjust the inputs and so on and so forth. So there are a couple of reasons, and of course the input costs and it can be capital intensive, so on and so forth. Unfortunately, the Americans never took to it, but the Koreans, the Japanese, the Europeans, except France and England, though they did initially have some very interesting work in this area, right? So why am I saying this? Sometimes I also feel I'm evangelist for hypothermia, but what I'm going to present is all science. So this is the kind after the history, let's look at this. This is our work somewhere here. You have all sides. This is breast, this is cervix, this is head and neck, this is my randomized trial, our randomized trial, prostate, pancreas, esophagus. This is, you can find this in Datta's meta-analysis, this particular table. So almost all sites he has compiled in a kind of a meta-analysis. So many of those randomized trials may be small, but when you combine them, there's a very high level of evidence for hypothermia being useful as an adjuvant to existing treatment like radiation and chemotherapy. Let's also start understanding and appreciating that if you look at the CS data, incidence is going up, but outcomes have stabilized over decades. So, we need to do more. We need to do more if we need to get the graph up. And remember, incidences of various malignancies is also going up. And hyperthermia can be used in most of the sites, like especially head and neck, which is our major problem. Now, how does it work? So there has to be, and it cannot be just an act of God. So there has to be some reason as to how it works. Now, there are two kinds of hypothermia. The kind of hypothermia we are talking about is raising the temperature from 30 normal temperature to 41, 42, 43 degrees Celsius. And when we do that, various things happen at the various levels of temperature, and that's why they call it as, with each increase in the 1 degree Celsius, 1 degree Celsius, there is a difference. There's a difference in outcome, there's a difference in response. And we must also understand that in life, all cellular mechanisms are essentially chemical mechanisms. And I'm sure we can all recall our laboratory experiments, and most of the chemical reactions are temperature dependent. So that's the reason, and that's a very commonsensical understanding as to why heat should be of consequence. Okay. Now, how does it work? When temperature above 41 degrees, differentiate mammalian sensitized cells to ionizing radiation, can activate G0 and S phase, preferentially kills hypoxic cells. Cell membrane may be the primary target, can inhibit DNA repair. These things sensitizes to radiation, and it can kill G0 and S phase. And it also can preferentially hypoxic cells. That's very important. Why? Hypoxic cells are the one which are very, very resistant to radiation. And they are probably even resistant to chemotherapy. So and also there are non-overlapping targets. Radiation acts on a DNA, but this can act on a cell membrane. It can act on many other, like cytoskeleton. I'll come to that next. Microenvironment is hostile in tumor to heat, and heat in turn perpetuates the state. Better thermal washouts in normal tissue reduces the cytotoxic effects. Therapeutic windows. Okay. Now we can all ask if heat is so critical for all the chemical reactions. The chemical reactions are seen in all the cells. So how do you create a therapeutic ratio, that window because of which heat works better and preferentially on cancer cells and not normal cells? Now, we are created to lose heat, okay? So it's always very difficult to treat a living human being or a living animal. And the tumor, which is hypoperfused, acts as a heat sink. So when you deposit the energy like this, it is preferentially absorbed by the tumor, which is hypoxic. And even if the same amount of energy is absorbed in normal tissue, because there's so much of perfusion, there's a washout. So there's a heat sink in tumor. The normal tissue, the temperature gets washed out. So there's a gradient. So tumor is hot, normal tissue is not. So tumor gets sensitized, and tumor is generally hypoxic. It's generally acidic. That's more sensitive to heat. Okay, next. So this is what I meant. This is how each degree, and as you keep on increasing, various biological events keep happening. Now, we very rarely get 45 to 46 degrees Celsius, wherein we can think of vascular occlusion. But sometimes you can see it at 43 degrees Celsius. And why it's all important is, no matter what, even if you're not, there was a time when we started hypothermia, we were all obsessed with 42 degrees, 41 degrees, we've got to do it. But it's very important for us to understand that even when you raise for something like 39 or 40, like we were discussing just now. And that's good enough to evoke a biological response. We were talking about the diabetic foot. Yes, I mean, perhaps that's the time that at this temperature, the vascular response is not of occlusion, but opening up. All right? So this temperature is important, and at each temperature level, it works in a different way. Say, for instance, when there's an increased perfusion at this level, something here, 39 and 38, what happens? Hypoxic cells get oxygen, right? They get reoxygenated. So when they get reoxygenated, they become more sensitive to radiation. So this is when you can have a cytotoxic effect due to hyperthermia itself. Now this column tells you at what temperature radiotherapy interacts the way with heat. All right. So remember, heat works at all temperatures above the human normal temperature. Next. All right. This is one of the very early laboratory experiments. These are all rats and all of that. This is the control. This is radiotherapy, hyperthermia, just one. Then radiotherapy alone. Then radiotherapy and four times heat. Okay? So controls, of course, we don't worry about this. But when you combine radiotherapy with hyperthermia at adequate number of times, or at an adequate dose, if you wish, we see a very decline in survival. This is control, this is survival. What does it say? Hyperthermia with radiotherapy is working here. Okay, next. It is also dependent on size, because you need to heat the temperature. You need to heat the tumor. So if you have a very big tumor, it may not be very easy to, or may not be possible sometimes to heat the tumor adequately. So that's why, this chart shows you how, survival improves when it's amenable for heating. Next. We were talking of targets for cell hyperthermia. Radiotherapy, we all know it's about DNA damage, DNA repair. We keep talking endlessly about that. But when it comes to hyperthermia, it's just not that. We have plasma membrane, we have cytoskeleton, we have nucleus. Right? So we have altogether different targets. What is the relevance of this is that you are essentially, it may be, cell may be resistant to DNA damage, but if you create a damage in cell membrane, what will happen? Say, for all your electrolyte traffic gets altered. You may promote influx of calcium. If there's an excess of calcium intracellularly, the cell dies, right? So the sodium-potassium pumps may get affected, and that may lead to cellular death or senescence. Cytoskeletons are very important in the cellular functions. Radiation may not affect this. Of course, DNA may affect nucleus, but since we have non-overlapping targets when we talk of hyperthermia, so it's very, very important for us to understand this particular fact of hyperthermia, because when you combine radiation or chemotherapy with hyperthermia, which are acting differently, different targets. It's like, Ukraine getting attacked from east, west, and somewhere else. So with various arsenals. It's not just the man with the boot, and not just in one direction. So when you have multiple modalities acting differently, not the same way, we have either synergistic or additive effects, which will increase the cell kill and the survival. Next. See, this DNA inhibition of DNA was very controversial, but it appears that now when you give hyperthermia in close, especially 41 degrees and above, when you give hyperthermia immediately after radiation, damage induced by radiation, or single-strand breaks or double-strand breaks, may get inhibited, in the sense that they may not get repaired. As a result of which, as a consequence of which, you may see the cell death. Next. That's just the details. Yeah, there can be a change in the tissue pH, especially with very, very high temperature, and that may be, inimical to the very survival of a tumor, and that leads to cell death. I mean, tumor death and cell death. Next. Okay, now I showed you one graph saying that not all tumors get equally heated effectively. So we need to be very careful in choosing your cancers. Now, when we're talking, even as a radiation oncologist, we understand that sarcoma is not as sensitive as, say, for instance, lymphoma. We know that. So we also should understand, and we should also know prior as to what are the kinds of tumors that we should really pick up for treatment. And there are various variables. Then the heat dose, the temperature over a time period is very important for the outcome. What kind of thermal gradients do we create is very important. Sequence and interval between two modalities. How do I treat? Simultaneously, one after another, hyperthermia before. This is still not, the jury is out. The jury is still out. So generally what I did was always follow hyperthermia following radiation, because I do believe that hyperthermia can inhibit DNA. So some people might think that, no, let me give hyperthermia, especially if I think that it's a little difficult to heat them. At least then there will be a perfusion, and there will be PO2 goes up, and then I will give radiation. Many times in the hospital, when you are treating many patients, it becomes at the end of the day a question of logistics. Best, perhaps, is simultaneous, but we still don't have many equipments to do that. As I said, depending on what you do, but it should be within 2 to 3 hours, within 2 to 3 hours of either way, either before or after, but don't have interval more than 4 hours. There are a couple of papers discussing that, and especially in the context of DNA repair. All right, most of the kinetics of DNA repairs, most of them by 6 hours, you have one half repair, right? The next. Yeah, so you must look for all these nutrient-deprived tissues. Next, low page. Next, okay. Now this is what I've been, trying to do with, propagate or investigate. There's something called low flow, further decline, high flow perfusion. The decline PO2 maybe lasts for 24 hours. If you have a low flow tumor, and based on your MRI perfusion studies, they are very, very suitable for treatment of hyperthermia. We don't have enough work to categorize on the basis of perfusion, or but this is one of my thoughts, which probably you as the youngsters can look at identifying the right kind of the tumor. Okay, if you have a very low flow, less perfused tumor, which is not very humongous, and these are the kind of the patients whom we can treat adequately, and you can perhaps hope for a better outcome. All right, next. Well, I mean, we all keep talking immunotherapy. Hyperthermia can also, and especially now these days, there's a lot of interest in combining hyperthermia, because it's immunogenic. It primes dendritic cells, etc. It deals with the natural NT cells, NK cells, natural killer cells, all of that. I mean, okay, but suffices to say at this point of time that hyperthermia is immunogenic. What was I saying? SBRT, or hypofractionated radiotherapy. There's a lot of interest in combining hypofractionated radiotherapy, okay, with hyperthermia, so that, because perhaps when you do hypofractionated radiotherapy, it also evokes a certain degree of immune response. And if you combine that with hyperthermia, which is also perhaps immunogenic, you will have a better immunotherapy, if you wish. Yeah, you're not doing anything extra. You're not giving immunotherapy costing thousands of rupees. But perhaps if you combine these two, which is part of your usual treatment, it could enhance the effect by being immunogenic. Next. All right. Now we all keep talking of radiation sensitizers. Of course, it's not anymore very, very popular, but especially in the 70s and 80s and the 90s, there were sensitizers, there was hyperbaric oxygen, so on and so forth. In fact, one of the sensitizers did have a level 1 evidence of effectiveness. Hyperbaric oxygen again had a level 1 effectiveness. Nicotinamide, if I recall right, also had a level 1 evidence, but they never became popular. That's a very funny thing about medicine. I mean, we all talk of evidence, we all talk of level 1, even when we have level 1, for various reasons, even amifostin, for instance. For many, many, many reasons, they don't become, what I think I'm talking to you all, standard of care or become a part of the routine care. So some of us should pause and think, why is it happening that way, right? I mean, we don't have to keep parroting, oh, but do you have level 1 evidence? Yes, there are many trials with a level 1 evidence which never became popular. Compare that with Bonner's. Bonner's had 235 patients or something like that. Level 1 evidence, everyone started using the cetuximab, right? Since I think most of you are oncologists, I'm going around all of the next. All right, now we should understand that there are various technologies for heating, and they all have different frequencies. This is how at different frequencies, it creates temperature or it creates heat, and they act differently in the body. But at the end of the day, the temperature goes up, and it inactivates the targets, and cell death takes place. What I have been doing is around 10 megahertz, 8 to 10 megahertz is my machine. It's called radio frequency capacitive heating machine. Right, next. So these are the various methods of heating. Inductive heating, radiative heating, capacitive heating, galvanic, and selective. This is selective impedance. This is one of those, he's Hungarian. His approach is different. He thinks that you need not increase the core temperature, because at that particular frequency, cell membrane, which has a bilipid membrane, has more resistance. When you pass this current at that particular frequency, selectively, the cell membranes get hot, and the consequence. And this is what I have been using. Most of my work is in capacitive heating. This was very popular in Japan. It's called Temetron, and they gave it as free as a gift. And I've treated more than 3,000 patients on that. Okay, this is all written here, and they all act differently. One of the advantages of capacitive RF heating at 8 to 10 megahertz is that you can have deep-seated heating. But as he was mentioning, it can be very painful sometimes. Some of the patients find it very, very stressful. After one session, they say, no, you're electrocuting me. I'm not going to take this. So, even when I started a randomized trial, even before randomizing, I would see as to whether they would tolerate that. Otherwise, the trial would have been very messy. Okay. All right. Next. This is how it works. This is a radiator wherein there's no contact. In a capacitive heating, there's a contact and a water bolus in which there's a 5 degrees. It's cooled to 5 degrees to cool surface area. And I think somebody asked me as to why I would not treat very fat patients in RF-based capacitive heating system. Is heat at the fat gets absorbs preferentially the energy, and they start getting hot, and not the tumor which is beneath that. So anything more than, we used to take a triceps measurement. If it is more than 1 to 1.5 centimeters, then we would not take those patients for treatment planning or treatment with hyperthermia. The next. Yeah, this is how it works. Electromagnetic heating, like this machine as well. That's ultrasound. This is perfusion. You can do an intra-arterial perfusion or hypic perfusion, and it's conductive heating. Your hypic, somebody does hypic here, and I think conductive heating is what you see in hypothermia, in a hypic. HIFU, we all understand HIFU, and that's based on ultrasound. This is what we're talking of, electromagnetic heating and hypothermia by perfusion, intra-arterial heart perfusion, like especially in olden days sarcoma. Not many people do that now. Next. This is whole body hypothermia. This is very interesting, and I think, in fact, whole body hyperthermia can be very immunogenic. Again, there's not much of work. It can be, you can have water bath, or you can have infrared. And when I went to Russia, in fact, those people were trying to treat patients with HIV who are drug resistant with a very high degrees of whole body hypothermia of 41, 42, very dangerous. But they would anesthetize the patient and, of course, monitor that and look at 41, 42 degrees for hypothermia. The reason as to why I'm saying this is heat, about harnessing heat. Predominantly, yes, it's cancer, but you can look at heat at different options also, maybe not just diabetes, but even psoriasis, wet psoriasis. Okay, and wet psoriasis, which is not responding to any of the treatment. That's another beautiful indication you can look at, you know. So next. So this is again it's a whole body, local, regional, local. That's how you can have in the local. You can have 45 degrees Celsius, 100 degrees Celsius. This is ablative hypothermia. That is HIFU or RF based treatment for liver metastases or bony metastases. There you are trying to induce necrosis. At this temperature, you are not inducing necrosis, but you are acting, the biological basis at this temperature is different, which we discussed before. Next. Yes. Now, hypothermia, as I said, there are various technologies and certain treatment planning systems, because you are a radiation oncologist here. Like in radiotherapy, various treatment planning systems are being developed because, there's something called a dielectric constant perfusion status that we were discussing about, or the fat layer that we were talking about. So we take a CT scan, put them all together, give all those values, and then, plan your inputs. Now, this is what you never wanted to heat. This is what you wanted to heat. So you can steer the input, and before doing that, you plan it on your CT scan, much the same way you do it on treatment planning, much the same way you do it for radiotherapy. They look beautiful here, but in the real clinic, it's always difficult because it's not as simple as it is in ionizing radiation, because the variables are too many. Some variables can be assessed, some cannot be assessed. Next. Let's complete all the technologies. This is interstitial hypothermia. You can use lasers, you can use microwave, you can use RF. I thought of including this because I think a few years back, there is one paper coming from MD Anderson for GBM, wherein they have been trying to do laser interstitial hypothermia. So that's why I thought maybe we should talk about interstitial hypothermia, but perhaps it may not be a great idea just to use interstitial hypothermia. We need to wait for this particular data. Earlier on, when interstitial hypothermia was tried for GBM or somewhere else, the incidence of necrosis was very high, and it was abandoned. So maybe not a great idea. The external or whole body, I think that's what we need to look at in combination with radiotherapy and chemotherapy. Next. Okay, this is the specification, as I said, of 8 megahertz. We have a parallel opposed fields like this, applicators, different size, so that we could steer and manage the depth of hotspots. Okay, this was given to us by this is called Thermatron. This was given to us free by Professor Sugahara from Japan. Next. Well, thermometry sometimes, especially in the initial days, was, everybody would say, no, we got to do a thermometry, we've got to do a thermometry. This particular one has invasive thermometry. And see, when you are putting in the needles, firstly, it's invasive. Secondly, you're not going to measure all the points. Okay? Now, there's a concept of T90, cumulative effect of temperature, CME, okay? But when you have just the few invasive needles, you never get it right. and you are approximating, and we all think, oh, well, we have measured T90. It is perhaps possible when you do a MR thermometry, but that's a very expensive and so on and so forth. And I'm very happy that when I used to go abroad, and I used to face the same question, and I used to say that, do you ever measure intratumoral cytotoxic agent concentration? You never do that. You're talking about body surface, this, that, etc., but that does not necessarily mean that there could be a tumor which is not very well perfused. So how is that it's going to go and hit every part of the tumor? It's not possible. But we don't discuss that. But when it came, of course, this is very important when you're studying, when you're trying to understand how it works, for the research and so on and so forth. And if you have this, especially in those machines where you can steer the input, you can change the inputs, maybe it's relevant, but not routinely. I mean, don't get obsessed with temperature. We'll try and extrapolate from what you have seen in vitro or some animal models and so on and so forth. And if you have MR-based heating systems with the multi-phased array systems where you can manipulate inputs, maybe you can go ahead with that. But it's always very difficult. It goes up and goes down. And these are, of course, when we present, we better present the best case scenarios, but sometimes it just goes up and drops and so on and so forth. And of course, there are a couple of thermometry measurements in docs that in that brochure that you can see. It's difficult to heat, but the good thing is, moment you increase the temperature by 1.5 degrees Celsius from the normal temperature, there is a biological consequence or a response which can be harnessed in the treatment of cancer. That's very important. If you can achieve 41, 42, nothing could be better. 45 is rarely possible. And I tried once using a tourniquet for one of the peripheral lesions. And if you do that, you can definitely raise the temperature to 41, 42. Next. Well, I think now this is, what I'm going to do is, I showed you in the first slide how globally there's a level 1 evidence. Maybe the numbers are small. When you combine them together, there seems to be a very robust level 1 evidence for many anatomical sites when you combine hyperthermia with radiotherapy. That was only hyperthermia with radiotherapy, not with chemotherapy, okay? The one by Jones and few others in breast cancer shows also hyperthermia with radiotherapy and calyx, that's an anthracycline, yeah? So this is what we generally do. This is for the head and neck one, complete clinical examination, laryngoscopy, etc., etc. You're doctors, so you know this. Next. The data I'm going to show, our patients initially were treated on cobalt, then on 6-MA accelerator. They were treated to a radical dose of 60 to 70. Next. Okay, so, well, when the chemotherapy became, or chemoradiation became the standard of care in head and neck cancer, we generally use cisplatin or paclitaxel at a fixed dose of 50 to 60 per week. Next. And we used once a week or twice a week. Most of the patients have received once a week, but as I was discussing, maybe twice or thrice, and you can categorize them and then see if there's a difference. Perhaps if you add, based on the first slide, initial slide, where in the rat experiments, 4 gave a better result than 1. Of course, the number of hyperthermia sessions depends on how long is your treatment, right? So when we do that once a week, you must have at least 1 hour because it takes time to heat. There's something called step up and step down hyperthermia and so on. So we'll not discuss that. We treat it for 40 minutes, and this is once or twice a week. The local area is to be heated is first pre-cooled for 4 to 7 degrees for 10 minutes, and then after pre-cooling, patient is positioned properly on the thermatron RF8 for heating. Electrodes are placed across the tumor for resistive heating or capacitative heating. Next. This is the sequence that we are talking about. Simultaneous is perhaps good, but it could be HDRT. But remember, don't exceed 4 hours between either these two sequences. Next. This is my 3 or 4 or 5 years old study. We have not published this though. Okay. Now, we have at that point of time 1488 patients, but of that, the number of patients that we could assess was 600. Of that, 603 were head and neck, and 515 patients were evaluated retrospectively. All right, this is not a prospective study. 320 patients, hyperthermic radiotherapy, and 195 HDRT-CT. This is very difficult to do this now because, suddenly chemoradiation is standard of care, though the difference is only 4% or 5%. But the moment you have something like a standard of care, to do something else becomes a little bit of a problem. Here we have done HDRT because we started much before chemoradiation became a standard of care. Next. All right, this is how this is all of them, 515 patients. Next. Oral cavity, nasopharynx, only 6. I generally don't like to treat nasopharynx, especially because it's a systemic disease, because it tends to metastasize. But in my youthful excitement, I did treat some nasopharynx. So we have oropharynx, hypopharynx, larynx, PNS, salivary glands, UKP. Don't treat salivary glands unless it's recurrent. Don't treat nasopharynx. Okay? Unknown primary, you can. Next. This is the profile and TNM distribution. Most of them are on a T3, T4, and N2, N3 lesions. That means they're loco-regionally advanced. Next. Well, this is stage-wise percentage distribution. That's what I just now said. Most of them, 26, 29, 25 here. Stage 1, no point in treating because, again, one of those silly things, when you're young, you want to treat everything. Don't do this. Stage 2, maybe you can. Stage 3, stage 4, definitely you should consider adding hypothermia. Next. Yeah, RT dose was generally more than 50 to 60 gray, and nearly 66.2% finished intended radical dose of 70 gray and around. Next. This is the initial response. Look at that, 74%. And 74% wherein predominantly is stage 3, stage 4 is very impressive. Yeah, if you're a pharmaceutical company, you'll really be very, very excited. Yeah, this is complete response. We're not talking overall response. Overall response is 98.3%. Remember, most of those patients were loco-regionally advanced, all 515. Okay, next. There's an association between stage and the response, and this is what it is. And as for A, obviously has a poor response, but stage 2 and stage 3 definitely have 96.1, 88.3. Stage 4A, when I say it is a poor, is still 71.4, and stage 4B is a little low at 46.5. Okay, these are based on TNM classification. Next. Okay, now next, that's what the hyperthermia. Now we'll look at each one of them. This is hyperthermia with radiation, 320 patients, same profile. Next. Yeah, similar, because mostly stage 3 and stage 4. And next. There we go, stage versus response. Again, see, look at this, 93.8, don't look at that, 85, 67, 40. This is only hypothermia and radiotherapy. Very impressive response. Okay? For a stage 3, stage 4, if you're something like getting 85%, it's very good. That's complete response. We'll look at survival later, if at all. Yeah, next. All right. It is for hypothermia and radiotherapy. What are the toxicities? These are all the responses. I mean, they're excellent, right? And as I said, my talk should not look evangelical. There are some side effects. I told you about stress, pain in some patients. But there can be grade 1 and thermal burns. And pain and systemic stress can be very, very, very difficult. That is in capacitative heating. Next. This is one of my patients wherein I had a thermal burn. Next. This was bad, and this is the only patient wherein I had a very bad thermal burn. the incidence of thermal burns, if you do it right, is not more than 0.5%. And very often, if you are not trained the technician well enough to tell him when to stop, then probably the incidence might go up. Next. All right, now we finished with radiotherapy and hyperthermia. These are all my data. We'll look at chemoradiation with hyperthermia. 195 patients, I guess. Next. These are all the drugs that we looked at. Arsenic trioxide, cisplatin, cetuximab, docetaxel, and some of those medications that we tried, but predominantly paclitaxel and cisplatin. Next. Again, the stage-wise distribution of 195 patients, it is no different from the previous one. It's just that we started adding chemotherapy because everybody said that you should add chemotherapy, that enhances. Perhaps it does, but there's a lot of toxicity. Sometimes, you start wondering as to whether it's really worth it, but that's a different story. Next. Yes, again, look at stage 1. I don't know why we even did that. But most of them are stage 3, stage 4, A and B, and stage 2. All right? 27.2, 30.3 plus 27.3. 27.3, predominantly advanced locoregional head and neck cancers. Next. Again, this is stage versus response, and you have fairly good response. 98.9, 92.5, 78, 54.4. Okay. Next. Now, this is one of the ICMR-supported randomized trials in head and neck cancer. This is published, and you might see it in many of the meta-analysis. This is a very small study of 26 and 28 patients. Next. Yeah, number of cases, the same profile. Mean age is around 58.42, and predominantly male patients, which we see in head and neck generally. Next. Yeah, again, oropharynx, hypopharynx, oral cavity. See here, no nasopharynx, right? I became wiser. Yeah, next. Yeah, this is the TNM staging classification. TN, next. I'm going to share this slide with Mr. Jannah. Anybody who wants to access them is more than ready, I'm sure, because this goes fast. So you may start wondering what it looks like. But this will be accessible for you. So you can anytime peacefully look at them. And if you still start wondering, if you have questions, you can email me, all right? This is what is very, very impressive. This is a randomized trial, small trial, but look at the difference. RT-HT had 78.6, and RT here is 42.4, the initial complete response. We're talking complete response. We're not talking overall response. And this is a randomized trial. Both groups were almost similar. Dose is similar. Sessions is similar. This is an impressive difference, though study is small. Next. When we looked at the Kaplan-Meier, and that also showed a significant difference at 2 years in survival. So overall survival, of course, because of the difficulty in follow-up, and these are all predominantly stage 3, stage 4. Survival in itself may not be very good, but we do see a difference in survival in favor of hyperthermia. And the initial response, if we go by that as a surrogate, there's a very significant difference with 78 and 42 or something. Yeah, that's quite a lot. And you rarely see that kind of a difference when you're looking at most of the contemporary cytotoxic drugs or targeted therapies. You got a very small, teeny-weeny difference in survival. Next. Well, we were talking of thermal sensitizers. As we talk about radiation sensitizers, can we increase the effects of hypothermia by giving certain medications? This was thought by many people. And arsenic trioxide is one of the drugs which is used in promyelocytic leukemia. It is available in the market. So we did see that arsenic trioxide was tried in animals as to induce vascular inhibition, angiogenesis inhibitor, more like an angiogenesis inhibitor, besides being pro-apoptotic. So we thought of creating vascular collapse because then heating becomes so much more effective. So then my the hypothesis was that if you do that, if you can heat better, and if you can perhaps achieve better outcome. This is a published paper in Orange Journal, International Journal of Hyperthermia, and this is the pro-apoptotic selective vascular inhibition, radiation sensitization by glutathione depletion, and that's why it also can be thermal sensitizer. Next. We have around 12 patients, and this is how it is. All kinds of patients, not just head and neck. Next. This is just a detail of all the patients, 12 patients. Next. Response was around 41.6%. Remember, these are all post-radiation recurrent tumors. There are nothing left. That's why this is only hyperthermia with the arsenic trioxide. This is not with any other radiotherapy or chemotherapy or so on and so forth. Why? We're trying to look at feasibility of looking at arsenic trioxide as a sensitizer of heat. And these patients had no future. So to see 41.6% of complete response and another 33.3, but these are all small numbers, so the percentages might look very handsome. But nevertheless, they seem to be good, and maybe it's again a worthwhile protocol to follow or pursue as a part of research. Next. Vomiting and allergy, but we had vomiting and allergy reaction in one patient, but everybody was safe, no problem. So we can use arsenic trioxide. It's in the market, as I said. At least it used to be in the market. It's used in promyelocytic leukemia, and there's somebody trying to use it. So one of the testicular tumors. I cannot recall. Yeah, next. Well, after bonus, cetuximab became very, very popular, and we wanted to look at whether we can combine cetuximab with hypothermia. And the idea was, I don't think there is any biological basis or in vitro to say that they are additive at a cellular level. My only thought was that if we can increase the perfusion and then excess of cetuximab intratumorally could be better, and that's how you could perhaps get a better outcome. And we have had around 6 patients, it's again published data. It's more as a proof of principle than any big collection of data. Yeah, and one of the fear, especially in cetuximab, is they all come up with skin reactions. So can I add hypothermia? That's another thing. Next. All right. So what we have done, we have seen many other drugs, in fact. We have done with nimotuzumab, we have done with cetuximab, we have done with cisplatin, we have done some taxane, radiotherapy with hypothermia alone, and we saw that there's a fair bit of evidence in multiple sites internationally, and this meta-analysis published by Dr. Datta is very, very informative, all right? So now, initially, I was talking to you about identifying patients for radiotherapy. For radiotherapy, for hypothermia. So we were talking about low flow, high flow, size of the tumor, nutrient deprivation, all of that. So you can look at them in various different fashions. There is something called texture analysis. I'm not sure how many of you are aware of this. This is based on your CT scans or any imaging that you do. It could be MRI, it could be CT scans, so on and so forth. So what we did is all these patients undergo CT scan as a part of the planning process. So we retrospectively looked at the texture of the CT scan. We have bought one software. This is raging right now, one of the investigational methods based on imaging. So I think this is from Oxford. Mr. Ganesh has been helping us. So this is called texture analysis. There are various kinds of texture analysis: statistical, structural, and spectral. We are doing statistical. Look at next. This is how heterogeneity is a key feature of malignancy associated with adverse tumor biology. So quantifying heterogeneity from imaging could provide a useful non-invasive biomarker. This is what it is, right? We retrospectively looked at patients who underwent hypothermia with radiotherapy. Next. This is called text. What we have bought is TextRAD. There are certain open access texture analysis software, but this is validated software. So that's why we had bought it. So next. Yeah. This is the published paper on the basis of our own analysis, but we'll go there next. This is called composite score. So there are various parameters, 3 or 4 parameters, kurtosis, so on and so forth. There are 3 or 4 statistical parameters I should have included. That deviation to the right, deviation to the left. So what we did was took our CT scan for planning. We sliced them at 3 levels: central level, 2 centimeters above, 2 centimeters below. Central level perhaps would have a lot of hypoxia score. Peripheral level probably more oxygenated, but we thought that will give you a kind, when you average all of them, will give a global information about the tumor. So when we did that, we evolved something called a composite score, and that could predict which of the tumor would respond to hypothermia, right? So our effort is, probably one of the ways of doing it is in future, and when you're trying to identify, it's a small data published by us, but people are interested. So if you ever get those software, it can have a predictive value. So it's very, very important. It's very important to identify the right patients so that you get the best outcome. So this texture analysis that we did perhaps is one way of doing it, besides what I told you earlier. Next. Composite score following texture analysis can help identify responders. Restricting the addition of hypothermia to those with higher composite score may yield better results. Quest for an optimal predictive assay is still a chimera. That's true, but we need to pursue. Young man, you could do that. Yeah? Next. Well, I mean, the other day, I was asked to talk about breast cancer, role of hyperthermia. There is. So I suddenly remember this slide. I mean, this patient had undergone chemotherapy, surgery, radiation, all kinds of things, right? Yet you can see the pigmentation due to prior radiation. So yet this patient had recurrence. So what do you do to this lady? Abandon? Just give painkillers? What do we do? So this patient, I recall, I had given hypothermia with a reasonably good response. And this is a very old slide of mine, so maybe I couldn't pull out that response of a patient. But just to remind you that hypothermia is feasible in a chest wall recurrence. And there's a lot of work that's going on in IIT Madras to come up with the microstrip arrays for chest wall. Okay, next. We also tried in a fixed tumor like this in a couple of patients. When you're giving, this is my thermocouple. This is what I was saying. Sticking 1 or 2 thermocouples, even measuring 3 or 4 points within this big tumor may not make much of a difference, but you will feel very happy that you have done some kind of a thermometry. All right? So this is one of those patients where I had treated with, putting, being a little innovative and adjust the applicators and try to heat this tumor along with radiotherapy because it was a palliative radiation resistant to chemotherapy, and so patient was in pain. So we should try and innovate and see how best we can use all the existing therapeutic modalities. And to my mind, hypothermia plays an important role and a very big role when you add it judiciously and appropriately. Next. These are the patients we should never treat with hypothermia. And this is even for palliation, because they're not going to respond. And all that you will say is, some people will say, see, I told you, hypothermia doesn't work. All right? So choosing the patients is very important. Next. I'm very happy that there are some people who are trying, in Thomas Jefferson, of combining olaparib, checkpoint inhibitor, with hyperthermia. This is listed, but active accrual is still not going on. Why did I get this slide in? This is an American trial, Thomas Jefferson. So I'm very happy that even Americans are waking up to the possibility of using hyperthermia more often. This is, of course, for breast cancer. Next. This is right now the trend, HIPAC, and local regional is slightly, these are the local regional. So with the effort of Mr. Jinnah and more people like this, him, I'm sure the use of local regional hypothermia will be like HIPAC, go up. Why? Because it has a biological basis, it has robust evidence. All that it needs is youngsters who are innovative, who are willing to explore, who are keen on helping patients, not follow some, like an automaton, the NCCI guidelines alone. I'm not saying don't do that. You must do it. But there's something beyond that. So this is the, I think this is the point I wish to share. Next. Look at Cochrane database. Yeah, Cochrane is very important. What does it say? Addition of hypothermia to radiation plays a complementary role. This is Cochrane, not me. RT plus HT leads to increase in CR, relative risk of 0.56, impressive. Lower recurrence rate, hazard ratio is 0.48. Improved survival, hazard ratio 0.67. This is Cochrane database. So this should make all the skeptics here, if at all there is one, to become more believers. Next. This girl, I owe it to her. She got the lecture on. Where is Preeti? She interacted with Preeti. She has been very, very helpful. So that's why I'm here. Thank you, Sejal. Thank you, Preeti. And thank you, all of you, for listening to me. And if there are questions, I'll be more than happy. I thought you'll interrupt me. None of you did. But you are more than welcome to ask me questions.